Tell me a story of a house MD type of interaction you have had. When I say house MD moment, I mean a time where a patient mentioned a completely obscure or seemingly irrelevant piece of information that allowed you to make a significant unifying diagnosis. Not joking when I tell you this. Patient with fevers, pulmonary infiltrates, and transaminitis. Was it treating empirically for pneumonia with minimal improvement? Consulted ID who came to do a more thorough exposure history. They asked him if he had recently had any exposure to ungulate placentas, and he admitted that he had recently assisted when his goat gave birth, had Q fever, and responded promptly to doxycycline. Bro, ID is built so different. What the heck is an ungulate fistula? Ungulate are hoofed mammals. Even for ID, I don't know where they would come up specifically with that question. I feel like it would have been something like, oh, have you had any exposure to farm animals recently? Are you sure that they specifically asked for ungulate placentas? It's a very specific way to mention that. But very interesting. And of course it is ID who is at the top of this thread here. I'm sure there's going to be plenty of ID in this thread because they are really our number one medical detectives, I think, for finding out all the weird history and weird pieces of information that cause people to get an infectious disease. One of my core tenets is never let someone die without trying doxycycline. I've heard of so many times people were super sick, and once they started doxy, they recovered. Of course, there are cases of overwhelming sepsis where it's too late, and also not everything responds to doxy, but this is still a good rule of thumb. Do you have a history of contact with ungulate placentas? Oh my God, yeah, how did you know? Incredible moment when I was a med student years ago on a rural family medicine rotation. 17-year-old with what she described to me as another yeast infection and usually cleared up with diflucan. I thought it was pretty straightforward when I presented to the attending. Attending comes in and starts asking questions about hygiene, and she says she washed her hands a lot and was a bit of a germaphobe. Do you ever use anything besides soap to wash your hands? I sometimes use bleach wipes. Pause. Do you ever use those wipes anywhere else? Sometimes I clean my arms and stuff because I feel gross. Do you ever use the bleach wipes down there? I sometimes do use the bleach wipes down there. Very long pause. This might sound a bit personal, but has anyone ever touched you in a way that you didn't like? Young girl, wow, what? Young girl starts crying and ultimately admits that she'd been sexually abused by a family member. What the hell? That just came out of nowhere. How did this line of questioning lead to the attending going down the sexual abuse path? That's crazy. I was in awe that the doc had that on her mind and was connected with her community enough to watch for those cases. Still think of it not too infrequently. Wow, I actually got like mild goosebumps from that. That was so crazy. Yeah, similar story. A few years ago, was seeing an elderly man with dementia frequently on house visits. His wife kept on calling us and finding it difficult to manage his behavior. Did what I could with carers, etc., but there was never really any acute behavioral symptoms. A few months later, saw the wife in clinic, my first time meeting her. Flicked through her history and frequent contacts for UTI-type symptoms. Never really had anything growing in her urine. At some point, as I was talking to her, the penny dropped. Asked her about her intimate life, and yeah, it turns out the man was essentially forcing himself on her regularly. Heads up on that kind of situation. Most people that have been the target of sexual abuse won't come forward unless explicitly asked, if they aren't the kind to come forward willingly. It's safe to ask just in case. You're right, I'm a paramedic and had a call for a young woman like 19 with abdominal pain, but in a public building. She didn't have a preference for hospital, which is odd, and her symptoms were also just sort of random. She had a suitcase with her, but absolutely did not look homeless, and she seemed nervous. So I asked her if there was anything else that might hurt, or if there was any way at all she may feel unsafe, or if anyone had harmed her in any way. She then broke down and started crying. It turns out she was being trafficked, but had no money /car etc., but was also scared of the repercussions of trying to get away. I asked her if she would feel better with a woman medic, and she said no, but she still felt scared that they may find her. I made sure to have the engine drive behind us, filled with 4 gigantic firefighters, and got her to a sane nurse and facility that could handle it. Contacted a social worker upon arrival, etc. That's not the only time I've had somebody not say anything until asked point blank. Sorry, I'm brain dead, but does somebody mind explaining the connection? Disclaimer, I have no medical training, but I know that people who've been sexually abused will sometimes obsessively clean their bodies or feel unclean when they aren't. Some examples would be using harsh cleaners like bleach wipes, showering with super hot water, or scrubbing at their skin until it's raw. Yeah, this is a very interesting kind of situation and very useful to know. I think this is something that I don't encounter that often in my line of practice, but probably, maybe there's times that I've missed it, missing these small connections like this. All right, next one is a patient presenting for a follow-up of scabies on her right arm. She was wearing a long coat into the office. Very run-of-the-mill visit until the end of the interview when she got hot and took off her coat. I noticed scabs on her left arm and asked if she had used the lotion on it. She said, "No, why would I? There is nothing there." Suspicious, I did a neuro exam, and it turns out she had partial hemi-neglect syndrome from a previous stroke without knowing. Wow, that's very interesting. So basically, when patients get neglect, they don't really feel anything on that side of the body, and they can't tell that there's anything wrong going on over there. And so they just completely ignore it. So that's a very interesting way for somebody to diagnose hemi-neglect in a patient. I was in fellowship, and the MA said, "Oh my God, that baby sounds so cute, just like a little kitten." Cryptococcal confirmed a month later. Yeah, that's very sad. My understanding is that Cryptococcal has a pretty poor prognosis. I think the life expectancy is like 5 years old, or maybe that's Rett syndrome. Cryptococcal. I think it has a pretty poor prognosis. Had a patient who I was admitting for CHF exacerbation. Okay, much more my neck of the woods now. She was frustrated at having been discharged for the same thing a month ago and gaining 25 pounds since. About 5 minutes into asking questions, she mentioned her stomach hurt and that she was taking something for it and if I could just order something for it. I asked her what she took, figured it was Pepcid or Tums. She took baking soda. 1/2 tablespoon of baking soda has over 600 milligrams of sodium. So if that patient was mixing a heaping spoonful with water a few times a day, like some of my elderly patients used to do, that would be a few grams of sodium a day. Recurrent hypokalemia in the hospital. No one could figure out why. R1 me was bored and walking around the hospital, saw her eating a huge bag of black licorice her husband bought. Turns out she ate one every day. Stopped the licorice, hypokalemia better. Actual house stuff. Okay, so quick review. So when you're taking too much licorice, it can allow cortisol to simulate what kind of condition? And that's hyperaldosteronism. And remember, with hyperaldosteronism, it's going to be making you pee out excess potassium. So 11 beta HSD, hypercortisolism, or licorice can cause cortisol to bind the mineralocorticoid receptor, simulating a similar state to hyperaldosteronism. So 11 beta HSD normally converts cortisol to cortisone, which does not act on the mineralocorticoid receptor. Black licorice, however, can overwhelm 11 beta HSD, so then you have too much excess cortisol going around and it's activating the mineralocorticoid receptor, simulating hyperaldosteronism. Very, very interesting diagnosis here. Should have also done a psych consult. Anyone who likes black licorice that much is not well. Bro, that shit is delicious. But I can get my food from anise or fennel too, so it's not the same. I recently had a conversation where people were saying, do they prefer red vines or Twizzlers? And I guess some people have very, very particular preferences when it comes to their licorice. Me personally, I don't feel like licorice tastes that good. It's kind of bland. I don't know. It's bland and chewy. I don't really like it that much, but it sounds like people really do like it a lot. Let me know if I'm wrong down in the comments below. Had a patient who had come in with bilateral knee pain and ER was about to discharge, but asked me, IM, to see and drop a note so that they could leave. Went to see the patient and he casually mentioned his left ear was also hurting, but he kept pointing to his right ear every time. Just for shits and giggles, I asked him to touch his left eye, and instead he touched the right one. So I asked him to tell me what's 2 + 4, and he couldn't answer. Sent him for a CTA of the head. Turns out he had Gerstmann syndrome with occlusion of the MCA. Gerstmann syndrome. I wonder if I have a card on this. I don't think I do. It sounds familiar. I have this Gerstmann-Straussler-Schenker disease. It's a type of prion disease, but I don't think that's right. So Gerstmann syndrome is a rare neurologic disorder consisting of a tetrad of symptoms, including acalcula, agnosia, agraphia, and impairment of distinguishing left from right. I'm sorry, but this sounds super shady. If I, ED, want to discharge a patient, I discharge them. If I want to admit, I admit. IM can discharge immediately if they want, but by hospital bylaws, they technically can't refuse admissions. It kind of sounds like your ED is suffering from a delusion that simply consulting IM somehow insulates them from a liability standpoint. Seems especially questionable since bilateral knee pain isn't exactly a classic reason to consult medicine, unless I'm grossly misunderstanding the story. Had a guy that came in with a sore throat and mild temperature. He had happened to fall and hit his head at work. So a head CT was done, found 28 ring-enhancing lesions all over his brain. So maybe like toxo or something. A battery of tests followed, obviously, with everyone suspecting cancer. But given his mild symptoms, it seemed unlikely. Anyway, we had a patient a couple of weeks earlier who had baffled us for weeks until we diagnosed cryptococcal meningitis, HIV negative. We added it just because we had gotten burned before, just being thorough, and it was positive. He then fell apart, needing multiple LPs, started losing vision. In the end, he was okay once treated. But that was 2 out of 5 patients with Cryptococcus we diagnosed that year, 3 of them HIV negative. Sore throat to fungal meningitis. Felt very house-like. Yeah, and there is actually one specific type of Cryptococcus that can affect immunocompetent individuals, and it tends to be in the northwest region. But you can actually look up a specific type of Cryptococcus called Cryptococcus gaddii. And this is a strain that lives in the northwest and affects immunocompetent hosts. So I'm curious to see if this person is in that area. Add on cryptoantigen to every LP, HIV positive or not. I'm told the test is 13 cents on the dollar and cheap AF per our pathologist and the neuroinfectious disease folks. It goes on every LP at my institution because of exactly cases that you described. So yeah, this is very interesting to me. Like learning little pearls like this is very helpful. Something that you wouldn't necessarily expect from reading a Reddit thread. Saw a lady with horrible myelopathy, looked like B12 deficiency, but I'm working her up for demyelination as well. My second time seeing her, she mentions offhand how bad her dentures fit and how she needs to use a lot of denture glue. Zinc toxicity from denture glue causing copper deficiency, causing myelopathy, mimicking subacute combined degeneration. This was literally a house episode. Oh, wait, actually, it is literally, there's a legit house episode on that. Season 7, episode 2. I had a lady come in because her tooth hurt. Her dentist told her it wasn't her tooth and that she could go to the doctor. It took a lot of questions, but eventually she said her tooth hurt more when she was at Walmart, which led me to think that her tooth hurt because she was walking more. Ended up getting a stress test because of a toothache on exertion, and it turned out to be coronary artery disease, and she ended up with 3 stents. That's crazy. What was the pretest probability? What was the index of suspicion? That's a great catch by this guy. Man, I can just see our cardiologists rolling their eyes over a stress test for a toothache. LOL. Great call. That's a hell of a catch. Even with that amount of information, for you to make that connection is very impressive. A patient had episodic spells of tachycardia and sweating every 3 to 4 months. Lab says he was hyperthyroid in one episode and right now. No more data. I think it may be Hashimoto's toxicosis, so I just handed him a new lab in 3 months, but he mentions he won't be able to do that because of a trip to his relatives. That sounds good. What do you do when you visit them? We hunt, at least 3 or 4 times a year. Spidey sense going off. What do you hunt? Wild boars. And do you eat every single thing, even the throat? Yeah, for burgers. Is it related? It is indeed. Poor guy was giving himself hyperthyroidism from the boar's thyroids. Turns out his relatives were getting the same symptoms, but they never bothered to mention it, assuming it was just the weather. Wow, that is crazy. Admit for stroke workup became a psych eval after I connected outside records and revealed the patient had been hopping across the US using ambulances, staying 2 to 3 nights in a hospital, leaving AMA, and ending up in another hospital across town or in the next town the same day, staying 2 to 3 nights, etc. I think I counted more than 15 head CT scans within 2 months, no nights at home or outside of a hospital. There were other records I couldn't access from other states that made me suspect that this had been going on for at least 4 to 5 months. From what I could read in the other notes, the other hospitals providers were not aware of any other hospitalizations. He left AMA shortly after I discussed my concerns of such frequent radiation and need for stable housing with him. We actually had a patient like this very recently at our hospital, and obviously I can't put too many details, but basically it was found that they had multiple different names and were going into every hospital in the country and kind of giving this elaborate story of all these medical conditions they had. It was just crazy because there was no objective evidence of those medical diagnoses. But then eventually one of our hospitals did some digging and found out this person had been using like multiple different names at all of these hospital stays. And he would have gotten away with it too if it weren't for you, meddling resident. I wouldn't be surprised if he is still getting away with it. Yeah, is this Munchausen's? Is this primary? Is this factitious disorder? Or is he doing it for secondary gain? and malingering for getting free housing from the hospital. But it's not really free housing if you're getting head CT scans every 2 to 3 days. I mean, that's definitely not good. First year of medical school, a friend of mine told me she was in the hospital after suffering a pulmonary embolism. Female, early 20s, healthy, extremely athletic, had just participated in a triathlon. Oral contraception as the only risk factor. Doctors at the large academic center where she was being treated were apparently at a bit of a loss. I thought back to our first semester anatomy lessons and the scalene muscle gap, and how our anatomy lecturer had mentioned that anatomical peculiarities there could lead to impingement of the blood vessels. And then I thought of the triathlon she had just competed in, and how swimming freestyle involved an arm motion that repeatedly compressed this region thousands of times in a row. So I did a quick Google search and came up with Paget-Schroeder disease, a form of deep venous thrombosis as a result of venous thoracic outlet syndrome. Suggested it to her, and she mentioned it to her doctors during rounds the next day. They sent her for Doppler ultrasound, compared flow in the arm down and arm raised position, and confirmed compression when her arm was raised. I was feeling a little smug for a day or two. I remember getting a UWorld question on this of a boxer who was practicing for an upcoming tournament with his punching bag. Crazy to see it in real life, because I feel like we just scoff at these zebras in questions since we just want the high yield stuff that we are more likely to see on the exam. I actually learned about this when I was a third year med student and my attending mentioned it. And basically, the situation that they saw it in, or they had seen a question on at least, was a patient who was, a construction worker and using a jackhammer. And so that repetitive up and down motion of that jackhammer led to Paget-Schroeder syndrome, leading to a DVT. And the other kind of similar question that you may get is there's something called the May-Thurner syndrome. And we actually had a patient with this just very recently. But basically, when you have your right iliac artery compressing your left iliac vein, so when the artery is like kind of compressing over the iliac vein like this, you get isolated left lower extremity swelling and a predisposition to getting DVTs there. In PICU, I got a 16-year-old transfer from surgery, second consult sent to them from nephro, with diagnosis of hemolytic uremic syndrome with hypotension, anemia, hemoglobin of 5, thrombocytopenia of 40, and an EGFR about 30. Patient had abdominal pain for about a week without diarrhea or blood or mucus, and had been seen by several providers before reaching our pediatric nephrology unit. So when I saw the patient for the first time, my impression was, how could he have such a reddened face and conjunctiva with a hemoglobin of 6? Then I saw myself the smear, and I didn't see a single schistocyte. After that, it turned out that before the week of abdominal pain, etc., he had several days of severe headache, malaise, myalgias, and some days of relief within, and hadn't told the other doctors. Also turned out he was from an endemic region for Hantavirus, hemorrhagic fever with renal syndrome, and he came back twice positive with PCR and serology. Is it a true house moment if you don't break into the patient's home first? Closest I have is Facebook stalking. Patient arrived to the ED unable to provide any history, found to lack capacity and require neurosurgery. Was able to tell us lots of convincing detail about a sister who worked in healthcare nearby, but when we called the facility, they denied her employment there. We suspected the patient was confusing time and the sister may have changed jobs in the subsequent years. Social work was unable to ID the patient or family. Finally, I got sick of the situation and found an employee at my hospital with the same job title and got them to look through Facebook for the sister's name. We found somebody who was a mutual friend and got the sister's number from them. Turns out my patient had been missing for over a year and the family was overjoyed to find them alive. We suspect this neurologic condition resulted in the patient being confused and unable to return home one day and have no idea how they survived the next year. There was this guy who came into the ICU intubated and sedated as a John Doe. Eventually needed someone to take him off life support. One of my co-residents, when he was bored on nights, started Googling all the women's names that the guy had tattooed on his body. That didn't turn up much, but then he cross-referenced against missing persons reports. Eventually found a Facebook post with a woman saying her boyfriend was missing and included a picture of him. Messaged her on Facebook and social work was able to track down family and eventually they withdrew care. Wow. There's lots of interesting stories and great catches in this thread. That was a really interesting read. And it kind of makes you think, how many of these cases are we actually not catching or not diagnosing? And there are patients who are in the hospital who we really can't figure out sometimes. And is it because we've missed some of these diagnoses like this and they're just waiting on that one tiny piece of information to really break open the case? Let me know in the comments down below if you've had any house-like moments or great catches. Very curious to hear what stories you guys have had or experienced. Thanks again for watching. I'll see you in the next one, and peace.